Good afternoon, ladies and gentlemen. I'm going to be talking today about the principles in the management of small bowel obstruction. So rather than going through the theoretical part of how we manage small bowel obstruction, I thought I would elaborate on this by taking a few interesting cases as case examples. And then we'll be able to see how we manage different types of small bowel obstructions differently. When I'm doing this presentation myself, my registrar is here, but I thought I'll do it myself because some of these cases are well before his time. So I'm more familiar with these than my current junior team. So we'll go through a few cases. I've got 4 cases in total. Hopefully we'll be able to get through all of them in the next half an hour or so. So the first patient is a 31-year-old lady who's a school teacher. She presented with a 3-month history of colicky abdominal pain, usually lasting 2 to 4 hours. And every time she gets pain, she also gets abdominal distension and vomits a few times. Quite fit and well, healthy lady. The only significant history of note is that she was quite obese many years ago. And she had undergone a laparoscopic Roux-en-Y gastric bypass some 3 years back. Somewhere else. Apparently, she was a BMI of 41 before she had the surgery, and now she's BMI of 27. So she's lost quite a bit of weight. So she goes to a GP with these symptoms. GP examines her. Abdominal examination is normal. The GP does a few tests. They're all normal. She's diagnosed as gastritis, and some PPIs are prescribed. And quite rightly, an ultrasound is requested. And she's asked to return with the ultrasound. Ultrasound also comes back normal. She gets some relief with PPIs. A week later, unfortunately, her pain gets worse. And this time around, her vomiting frequency also has gone up. She's vomited about 10 times now in less than 24 hours. Okay, if I can perhaps ask the juniors in the audience to tell me what you think about this. It's an abdominal X-ray. Just shout out. Doesn't matter even if you're wrong. What's this talk on? What's the topic of this talk? You saw that right at the beginning, small bowel obstruction. Okay, so this is a classic abdominal X-ray of small bowel obstruction. So, I mean, no prizes for guessing that, but can you tell me why we say this is small bowel obstruction? Give me 2 very important things on that abdominal X-ray, 2 markers, an examination question. Why do you say this is small bowel obstruction? Is it because the bowel is dilated? Okay, well, you get dilated bowel in both mechanical obstructions and pseudo obstructions. So the fact that the bowel is dilated doesn't really mean that it's a mechanical obstruction, right? It could be ileus. You have gaseous bowel all over. So it is dilated, yes. And these are small bowel loops. And why do we say these are small bowel loops? This is not a large bowel. This is a small bowel. Why is that? Do we have a pointer here? No? See, there's something called step ladder pattern. I mean, this is just basic stuff, MBBS level stuff. Step ladder pattern, and that's because the valvulae conniventus get really prominent when the bowel gets distended. It's not that prominent in a non-distended bowel. And again, step ladder is not the kind of steps that you see from below upwards. That's not step ladder. It's the lines that go from one end of the bowel to the other end of the bowel throughout the dilated bowel, which is what the valvulae conniventus are. So that's what this is. So a CT was requested for this lady. And there's definitely something abnormal there. I mean, any guesses as to where you see the problem is? I know it's not a very good film. It wasn't done here. It was done elsewhere. So what we see here is, unfortunately, we don't have a pointer. I don't know if my mouse is showing up. No. Okay. So what we see here is clumping of small bowel mesentery right at the root, and obviously dilated small bowel. And what that line there is nothing but a gas fluid level. So it's a horizontal line. So it's a dilated small bowel with a lot of gas in it. It's It's because the patient is supine, you see it horizontal, and there's a lot of clumping. The arrow mark there refers to the clumping of the mesentery. And this is the kind of pattern that you would see with internal hernias. Okay, it's quite a rare condition. We're all aware of abdominal wall hernias. They come under the category of external hernias, but there's something called internal hernia, and it happens particularly in patients like these who have lost quite a lot of weight. So it's just a learning point here. If you come across a patient who was massive at one point, and then now he's lost a lot of weight, and he comes with colicky abdominal pain, do think of internal hernias. And that happens because the mesenteric defects open up during the weight loss. So, yeah, so just a few words about internal hernias. So when the roux loop goes up, when the small bowel goes up, and there is a potential space that develops between the bowel and the mesentery, and there's about 4 different spaces. We won't go into the details of it. That's pure surgical. I know it's a mixed audience here. So sufficient is it to know that internal hernias can develop and small bowel obstructions can happen because of that in people who have lost significant weight. And the thing about internal hernia is it's very, very difficult to diagnose clinically, unless you have an extreme high index of suspicion. And if it is not diagnosed at the right time, and if appropriate treatment is not initiated, these patients can end up having small bowel infarction, strangulation, peritonitis, septic shock, and so on. Right. So the treatment for this is almost always surgical. So it's a block. It's a loop of bowel which is caught in a space that needs to be released, and that's the solution. Nothing else. So we'll move on to the next case. This is a 64-year-old lady. Again, this lady is also quite fit and well. She presented with nausea, vomiting, and upper abdominal discomfort for about a week. She was tolerating liquid diet okay. She didn't have any bowel or urinary symptoms. Clinical examination was normal. Diagnosis, possibly gastritis. This is the initial diagnosis. This is even before she gets to the hospital. PPIs were given, some antiemetics were given, and she was probably a bit all right after that. Now she's able to tolerate liquid diet. And the advice given to her was that she should have an endoscopy at some point. Unfortunately, 3 weeks later, her symptoms continued. And this time around, it wasn't, earlier she was able to tolerate liquids, but this time around she had some problem with fluids too. So it's not just abdominal pain, but difficulty in keeping the fluids down. And interesting enough, this lady has lost about 10 kilograms weight in the intervening 3 weeks. So now she's not quite as well as what she was 3 weeks earlier. She's tachycardic with some epigastric tenderness. Some bloods were done. White count is raised at 20. MLA is significantly raised. So 716. So that's about 3.5 times normal. Nothing much on the X-ray, chest X-ray, abdominal X-ray was this. Any thoughts about what you see here? I mean, let me be honest. When I looked at this X-ray, I didn't make much out of it. To me, it looked like a normal X-ray. I didn't see, there is a pathology there. With hindsight, I can tell that there is a pathology. We'll come back to this X-ray later on. But at first sight, I could not see any problem there. There is a problem on the CT. The pathology is on the CT, but it's very, very difficult to spot the problem out. Again, a poor quality CT, not done in our hospital, it was done elsewhere. Okay, let me take you to that opaque thing there. Okay, there's a right kidney, there's a left kidney, and just above and to the above and medial to that right kidney, there is an opaque shadow. Are you able to see that? An opaque shadow. So what do you think that might be? That opaque shadow there, superior medial to that right kidney. It can't be a kidney stone because it's away from the kidney. So what else could that be? Well, when somebody just shows that, the first thought would be, is it a big, is it a foreign body? Is it something? But look at this view, the coronal view. The same opaque shadow is seen again. So it is seen there. So that opaque shadow, let me place you. That opaque shadow is not in the kidney. It is not in the gallbladder. It's not in the liver. It's in a luminal structure to the right of the midline. What is it? Very difficult to tell. So it's a very, very unusual scenario that we are dealing with here. It's a gallstone. It's a gallstone, but just a gallstone in the wrong place. A gallstone which is not in the gallbladder. It's a large intraduodenal gallstone. It can happen. It can happen, and we'll go through the academic, the literature part of it in a little while. So it is nothing but a large intraduodenal gallstone which was causing complete obstruction of the duodenal lumen, resulting in gastric dilatation and repeated episodes of vomiting. And the last line, quite interesting, gallbladder was not visualized. This lady had not had a cholecystectomy. Okay, so a lady with no cholecystectomy history, having a big gallstone, not in the gallbladder, but in the duodenum. So, sorry. So it is in the duodenum. So obviously, it is well within the reach of a gastroscope. So, options, endoscopic, surgical, and nobody wants to go for a surgical treatment straight away, particularly when things are not too bad. So an endoscopic attempt was made, and that's what it looked like at endoscopy. Large stone, almost complete obstruction of the second part of the duodenum, and retrieval was not possible simply because the guide wire wouldn't go beyond the stone, and you got to get the guide wire beyond the object for you to retrieve it. So that wasn't possible. And so we ended up doing a laparotomy on her, midline laparotomy, and the stone was felt in the second part of the duodenum quite nicely. So standard duodenal cauterization. I did try to milk the stone into the stomach or milk it down to the jejunum. It wouldn't work. It wouldn't work because it was just, the stone was just a cast of the second part of the duodenum. The reason I wanted to try to milk it to stomach or to the jejunum was that opening the stomach or opening the jejunum is a much nicer job to do than opening the duodenum. So we tried, didn't work. So we had to open the duodenum, and the stone was extracted. A two-layer duodenal closure was done. That's what the stone looked like. It's a 7 centimeter long and about 3 centimeter wide. So yeah, so the patient did well, discharged, and she's been followed up, and she's absolutely fine. So what is this? So it is technically it's a gallstone ileus, except that it's a very rare form of gallstone ileus. I mean, gallstone ileus itself is a rare cause of small bowel obstruction. It's about 1 to 2% of all small bowel obstructions, and it's nothing but a cholecystoenteric fistula. So it's a severe inflammation of the gallbladder, causing the stone to erode through the gallbladder wall and enter into a neighboring luminal structure. It could be jejunum, it could be colon, it could be duodenum, but entering into a duodenum like this is extremely rare. And wherever it goes to that area and it sits there, and it blocks the lumen. And patients with gallstone ileus, they don't come with upper abdominal pain, the classic biliary colic. They come with small bowel obstruction. So that's what this lady had. And the most common place where the stone would get lodged after it had got eroded through is the terminal ileum. Now that's a trick question, or rather quite a difficult question, but don't worry if you don't know the answer to it. There is a particular name given to a condition when the stone in the gallbladder gets eroded and gets stuck in the duodenum, right? In the whole spectrum of gallstone ileus, this particular form of gallstone ileus has a name, If anybody knows the name, please shout it out. Okay, it's called Bow-Breath syndrome, right? Bow-Breath syndrome, you can note it down if you wish. It's a very rare condition. And as I said, gallstone ileus itself is only 2% of small bowel obstruction. Bow-Breath syndrome is about 3% of that 2%. So it's a very rare condition. I'm sorry. It's a very rare condition. And first described in 1896, Leon Bow-Breath, a French surgeon. Most of the time, endoscopic options, lithotripsy options don't work where it is when it comes down to Bow-Breath syndrome. Surgery is the mainstay. And if I can take you back to the history of this patient, if you remember, the amylase was 716, right? So the lady not only had gastric obstruction, gastric outlet obstruction because of the stone of the duodenum, but also had hyperamylasemia because of block of the pancreatic duct by virtue of that stone sitting there at the ampulla and blocking it. So it's a combination. It's a combination of a Bow-Breath syndrome with pancreatitis. So we looked it up. We looked it up to see. There are a number of cases of Bow-Breath syndrome in the literature. But when we looked up as to the number of cases who had Bow-Breath syndrome and pancreatitis at the same time, we could only see one previous case reported in the literature. So we decided to write it up, and we got it published in one of the journals. And we also had it presented in a few conferences. Bow-Breath syndrome presenting with acute pancreatitis as a very rare and challenging variant of gallstone ileus. So that was the second case. So we've got two more cases to go. So this is a 39-year-old lady, an IT professional, 2-week history of colicky abdominal pain, which got worse in the last 24 hours. She had vomited 3 times. Some abdominal distension, but she's still passing flightus. Apparently, she's had similar episodes 5 times in the last 15 years. So there's a clue there in that line. More clues. She had a laparotomy 7 years ago. We don't know for what, but she's had anal surgery. She's had perianal abscesses, drainages recently, and she does have problems with weight gain. So any guesses as just a differential diagnosis? I mean, the markers there to point you towards a diagnosis are, number one, she's a young lady, middle-aged lady. Middle-aged lady who's had these kind of colicky pains on and off for 15 years. And she doesn't put on weight. Great. Fantastic. That's exactly what we are dealing with here. IBD, inflammatory bowel disease. If I may ask the gentleman who typed that answer, which of the IBD do you think this might be? The 2 common IBDs are Crohn's disease and ulcerative colitis. The question is open here too. No, it is Crohn's disease. Okay. Perianal involvement is a classic hallmark of Crohn's disease, not ulcerative colitis. Ulcerative colitis involves the rectum, no doubt, but patients with ulcerative colitis don't get as much of perianal problems, abscess drainages, and so on and so forth, as the Crohn's disease patient. And not that ulcerative colitis patients will be, obese or anything, but weight gain is more of a problem with Crohn's disease patients than ulcerative colitis. Now, if you, so the next 2 slides will give you good information about why this is Crohn's disease. So she's thin-built, she's anemic, abdomen is a bit distended, bowel sounds exaggerated, as you would expect in a mechanical bowel obstruction. Digital examination is empty, and that's the drug history. Okay, so classic. Most of the time, this is another interesting thing. These patients, the IBD patients, usually middle-aged patients, they've lived half of their lives with these kind of problems, and so the medications, the names of the medications are all on their fingertips, including the doses. So they tell you, doctor, I've been on this, mesacol, 800 milligram 3 times a day, I do take prednisolone, 40 milligram everything is there. The drug history will give you a good clue about the etiology for small bowel obstruction. So you've got to take the drug history, and it will take you straight to the diagnosis. And this lady apparently was placed on an immunomodulator also for about 6 months, but she's not had any biologics. That's the abdominal X-ray. Okay, so I'm not going to ask you this. It's a small bowel obstruction again, a stepladder pattern, more in the middle of the abdomen. Okay, can anyone tell me what you think about this CT? All the arrow marks point to the problem that she's currently experiencing. What do you think of the bowel? Yeah, I take your point. There is a stricture there. There's a long stricture there in the right iliac fossa. Anything else? What do you think of the bowel wall? You talked about the narrowing, but what do you think of the thick end? Yes, those are important things. So, and of course, the bowel proximal to it is dilated. Okay, so we have three important features here. One is grossly dilated bowel with air fluid level. There is an air fluid level right on the top. There is there's a long narrowing of the bowel. I mean, a radiologist will be able to measure and tell you exactly what that is. 10 centimeter, 8 centimeter, something like that, I would have thought. And then the bowel wall is thick too. So all of these are classic features of small bowel Crohn's stricture. Okay, so it is a high-grade small bowel obstruction. Right. What next? High-grade small bowel obstruction, Crohn's patient who's had loads and loads of medications over the years. What would you want to do? Carry on with more steroids, or would you want to go for surgery? Okay, well, there are specific guidelines about who you should operate and who you shouldn't. I recommend you go through these. Just to summarize, the ones who go for surgery in Crohn's disease are the following. People who have failed medical therapy. They don't necessarily have to come with obstruction. There is a role for surgery, even when they are not obstructed, but there are specific criteria as to how you would categorize them as failed medical therapy, patients who have failed medical therapy. And then the second category is all these things, emergencies. They're perforated, they're fistula, there's a fistulization there, there's an interloop abscess, not amenable to drainage. Third is what we are seeing here, an obstructed patient. And of course, when they develop carcinomatous changes within a stricture. Significant growth retardation, interesting enough, is also an indication for surgery. So somebody is really, really malnourished. And on top of that, the lady is on immunomodulators and steroids and so on and so forth. You might be, there's a good case, there's a good argument there to get her on straight to surgery for resection of that disease segment, as opposed to just carrying on the same pathway for decades together. Okay, two kinds of surgery is normally done in these kind of patients, either a stricturoplasty or a resection. Again, there are specific indications for either procedures. If the strictures are multiple, and if the bowel segment is quite long, there is a role for stricturoplasty. But if they're all within a foot or within half a foot, the better option would be to resect and join up. These patients have multiple surgeries during their lives. If some of these Crohn's patients, they end up having one surgery every decade. So at the age of 21, then 33, 44, 50. So you got to think, has she got enough small bowel inside, considering the fact that she's already had 3 in the last 30 years. So those are patients on whom you may have to consider stricturoplasty rather than going for resection. So again, I won't go into a lot of those details. Are very, very surgical there. So we will try and keep it as general as we can. So yeah, so Crohn's strictures. they could be inflammatory strictures or they could be fibrotic strictures. If they're inflammatory strictures, there is a role for medical therapy. But if it is fibrotic, it requires surgical intervention. So how do we know whether it's inflammatory or fibrotic? An MRI helps. But as far as the general cross-sectional imaging is concerned, CT scores much higher. A CT enterography scores much higher than an MRI or an ultrasound. But if you want to specifically look at whether it's fibrotic or inflammatory, and if you want to get more information about the level of active inflammation, MRI scores slightly higher than the CT. So that's just a bit about the Crohn's stricture. Last case. 67-year-old lady who's a pensioner, colicky central abdominal pain, 24 hours, bilious vomiting. She last opened her bowels 2 days earlier. Now she's not passing flatus. No red flag symptoms. She's all right otherwise. No PR bleed, no loss of weight, no change in bowel habits. Diabetic. So 67, diabetic, hypertensive. So that's her surgical history. So she's had 4 surgeries altogether, right? So one cesarean, one hysterectomy, and 1 appendicectomy. So the abdomen has, 1 cesarean, 1 hysterectomy, and 1 appendicectomy. 3 surgeries altogether. So there's 3 scars in the abdomen. I'm emphasizing on that because the clue to the diagnosis is in that particular statement that I've just made. She's had 3 previous surgeries. 50 per minute heart rate, probably because of beta blockers. BP normal. A bit dry. She's distended. She's got tinkling bound sounds, generally tender, but no peritonitis. And as I told you, all these scars are there, but there are no hernia. No hernia in any of those scars. Rectum is empty. Any clues? Any diagnosis? You want to shout out? This is probably this is the clue. This is probably the most common cause of small bowel obstruction in the elderly, which settles with conservative management. So if there is a small bowel obstruction which was going to settle, it would be this one. Okay. So that's her X-ray. Okay, so this is an adhesive small bowel obstruction. Okay, when people have when the abdomen has been entered a few times before, adhesions develop, and it's not a virgin abdomen anymore, and bowel can go between adhesions and get kinked. And most of the time, it is estimated 80 to 90% of the time, bowel obstructions that happen because of adhesions, because of previous surgeries, settle with conservative management. So the last thing you want to do on this lady is surgery. So conservative management means these things: nil by mouth fluids, nasogastric decompression, urinary catheter, and it's also careful monitoring of certain parameters, not just putting the patient on a drip and forgetting about, you've got to keep doing things actively too, in terms of performing certain investigations. Each of those investigations has a significance. If you look at the white cell count, somebody on conservative management has an elevated white cell count, you think about ischemic bowel. Is the bowel not settling? Is the bowel not untwisting itself, and is it going towards ischemia? When the urea creatinine goes up, you ask yourself, are we doing enough with fluid replacement? Repeated vomiting will cause low potassium. All of us know that. And the metabolic status of the patient, repeated ABGs, extremely important. And the last line is very important: persistent lactate elevation. It's not just one-off lactate elevation. So you do see patients coming from time to time to the emergency with a lactate of 2.5, lactate of 3.5, abdominal pain, vomiting, distension. Fair enough, that patient requires admission, and there is a strong suspicion of ischemic bowel there. But that's only part of the story. The full story is that lactate has to either remain that way despite adequate resuscitation, or it needs to be going up despite fluid resuscitation. That's when you start really worrying about ischemic bowel, infarcted bowel. If it's getting better, what you saw in the emergency was just a reflection of poor perfusion of the tissues generally, and not necessarily a small bowel ischemia. So it is, that's very important. That series of lactates done over a period of 24-36 hours. There are specific guidelines for adhesive small bowel obstructions too, and I would encourage you to have a read through. So it is a busy slide, but I will just quickly summarize this. Okay, so see, this is the flow chart in that guideline that I showed earlier, Bologna guidelines. I'm sorry about the font size, but what it essentially says is if the patient comes with adhesive, with suspicion of bowel obstruction secondary to adhesion, and if the patient has had strangulation, bowel ischemia, peritonitis, the answer to the flow chart ends there. You got to go for surgery. But if that is not the case, you do a CT with contrast, water-soluble contrast, and put the patient on conservative management and watch, get another abdominal film. The flow chart says here that you got to get one in 36 hours time. But that's, in clinical practice, sometimes you are allowed to vary a bit, 3 days, 4 days. If the contrast has reached the colon, you carry on with conservative management. There's no harm there, provided all the lactates and everything is okay. But if the contrast has not reached the colon, and if the patient continues to have bowel distension with or without any hemodynamic abnormalities or lactate abnormalities, that's when you start worrying and you stop your conservative management and you go for surgery. So that's regarding this particular case. So lastly, small bowel obstruction. I mean, if you are asked this question in the exam, what are the causes of small bowel obstruction? This is how you support. Even in the fellowship examination, the candidate is expected to answer just this way: extrinsic causes, intrinsic causes, and intraluminal causes. In fact, what we have seen today, we've seen 4 cases today, right? The internal hernia was extrinsic cause. The Bogarth syndrome, the gallstone inside the duodenum, was an intraluminal cause. The adhesion was again an extrinsic cause, and the IBD, the Crohn's disease, was an intrinsic cause. So there's, just remember a few in each of those categories, and that's how you tell the examiner, and you will get through. So that's all my presentation for today. Thank you for your patient listening. Yeah. So I'm happy to take questions.